So for our first rebuttal, our opponent's argument was that opioid abuse in the U.S. is related to prescribing patterns and accessibility of hydrocodone. If that is correct, then the true target for decreasing opioid abuse should be prescribers. Changing the law regarding controlled schedules and targeting prescribing practices, of course, will not attack the problem of illegal obtainment of opioids online. But currently, physicians are not required, as far as I could tell, to complete any continuing education specifically related to pain management. So requiring pain-related CE for physicians, like what is required for pharmacists, could help physicians improve their prescribing practices by becoming more knowledgeable about the types of pain medication, their indications, and their potential for abuse. And in addition, requiring documentation of the reason opioids were prescribed could also influence prescribing practices. And for their second point, they argued that no difference in abuse liability exists between hydrocodone, oxycodone, and hydromorphone. But I would like to point out that the doses used in their study for hydrocodone was 15 milligrams, 30, and 45, but the combination products only come in 5 milligrams, 7.5, and 10. So, of course, the combination products would not really be applicable to their study results.
In addition to the study that they used that said hydrocodone would fit more in line with other C2 drugs, I would like to point out that that article was posted months after the proposed rescheduling of hydrocodone products. I think that it's very ironic and probably politically charged that just months after this rescheduled proposal, a study comes out saying, yeah, we support this change. When just 3 years prior, in the same journal of medical toxicology, there was a study that said the complete opposite. It was actually a study of 9 studies that were all double-blinded, randomized, and placebo-controlled trials. And it found that oxycodone had significantly elevated abuse and liability profile compared to hydrocodone. So that is in direct contrast to the study that came out after the proposed reschedule change.
Another thing about that study is that it had a sample size of 9. I mean, that's kind of small for us, for a good, accurate study. I mean, I'd like to see more studies based on that, see if you have a lot more patients to see if we can get that a stronger correlation. For the last part, the CDC recognizes opioids as a major public health concern. The presence of guidelines does not guarantee its use. Prescribers don't have to follow this guideline. I mean, they're guidelines. They're there to guide you. Most doctors probably are just going to ignore this anyway and continue what they're doing because patients will just come up to them and beg for it. And most of the time, when they beg for it, they do get it. The pharmacy itself is not always, and prescribers, most of the regulation is going to be more on the pharmacy and pharmacy itself, and the pharmacy is not always equipped to handle the help with these recommendations to these doctors if the doctors aren't going to help listen to us. Regular evaluation, including monitoring abuse and misuse, may result in stigmatizations, meaning that patients may be looked at as, okay, they're junkies, they're not there for just legitimate pain, which is why we think that we should reduce this back down to Schedule 3.
Now for the con side.
So our opponents brought up an interesting topic about regulatory barriers in long-term care facilities. But under the law, long-term care facilities are actually exempt. They have special exemptions. They're able to actually accept C2 scripts via fax. And they can get, like, quote-unquote refill prescriptions. They can continuously send out partial amounts. And the other thing is that with long-term care facilities, you almost always have a physician or a physician's assistant that's on call, that's there to evaluate patients and to be able to write the scripts. And then e-prescribing is extremely popular now. A lot of long-term care facilities are switching to it. And facilities know that they can get even more Medicare reimbursements when they decide to go over to e-prescribing. So it's an incentive for physicians to do that. And so this is actually, it significantly decreases the workload. These patients don't have to get up and go to the physician. There's always a physician or a PA on call. and it reduces that through communication that's necessary in order to give these patients what they need.
The second rebuttal was against the point that was that changing it to C2 reduced legitimate patient access. And I do feel that is a legitimate concern. As pharmacists, we should, before all, value our role as a caregiver versus a gatekeeper. But the challenge of obtaining C2 medications is not typically in obtaining an amount of medications that is reasonable to treat pain in an acute situation, such as a 3 to 7 day supply post-procedure, also a CDC recommendation, but rather a script for 120 plus pills with an excessive frequency. Having worked in a community pharmacy, typically pharmacists are not opposed to filling a script for 30 pills, 60 pills, but when we start getting into the higher and higher numbers, that's where the objection comes, especially in new patients. So the way we can make sure we're still giving the adequate care is perhaps pharmacists should ally themselves with pain clinics, because patients who require the higher volume of hydrocodone should likely be evaluated by pain services regardless. And I don't know about all of the pain clinics, but I know personally where I practiced, it was in a hospital setting with an associated pharmacy. The decisions made by those physicians could be at that time called at any time by the pharmacy to confirm that the medication was being used for a legitimate pain. So not so much that we should worry, like in terms of reducing the access, we can make sure that the patients who need the medication actually get the access by allying with somebody who can evaluate them.
And then in response to the last 2 points, one, that this switch has resulted in increased healthcare costs. Yeah, that might be true. Patients will have to see their physician more frequently. They'll be monitored more closely. They'll need more prescriptions. This also goes hand in hand with reduced emergency department admissions, reduction in overdoses, which ultimately cut down costs in the long term. And keep in mind that much like with the long-term care, physicians do have the option of sending electronic prescriptions. They can do that without the patient even being there if they so want. And actually a lot of states are switching to electronic-only C2 prescriptions. There are a couple of states right now that have implemented this. So ultimately, this shift may potentially increase healthcare costs, but with the benefits, it might actually serve to reduce costs overall. And then finally, there's the claim that it might shift people to the black market. Well, this might be true of a medication that goes from a Schedule 2 to a Schedule 1 that has no legitimate medical purpose, as we might have seen with fentanyl. You might see people that go and try to buy these medications more from the black market. But keep in mind that this medication, hydrocodone, is just going from Schedule 3 to Schedule 2. So there still is a legitimate medical reason, and they can see a physician and get these prescriptions regularly. So there's really no reason for them to have to go outsource to the black market. They can continue to get it through the same prescriber they've always gotten in the past.
Let us thank both of our panelists.